topic for today, as you said, it's very important for every obstetrician, as obstetric is the most litigant branch of medicine. Almost 80% of the medical legal cases are obstetric related, out of which 80% are cesarean section related, and 80% of the complications in cesarean sections are hemorrhage related. We, the obstetrician, has a dual responsibility and deals with the two patient and two litigant, one visible and another is non-visible. So the cases are also doubled. Pregnancy is taken as a physiological phenomena, and pregnant human are usually young and healthy. A positive outcome is expected in pregnancy, parturition, and subsequent hospitalization. But obstetric is full of unpredictability, and fatal complication can happen anytime in spite of the utmost care and caution. Any bad outcome is not acceptable by the public and the relative, and they label it as a negligence, and it becomes a chance to litigate the treating doctor. In obstetric, no single topic is so controversial than that of cesarean delivery, and the cesarean section is one of the most commonly performed operation in obs and gynae practice. Though the cesarean section is life-saving in certain medical situations, indeed it can be associated with several medico-legal issues. And once the legal dispute starts, it is not only costly, lengthy, go on for years, but very demoralizing. I'm sure those who have experienced will agree to it. There is a constant and steady rise in the incidence of the cesarean section globally in recent years. The overall incidence is around 17% in India, depending upon the variables like place, region, cities, and sector. It has crossed the WHO threshold of 15%. On an average, Delhi government sector, the incidence is around 25%, which becomes and increases to almost 50% in the private sector. Cesarean, and in cases of the ART conceived pregnancy, it is almost in the tune of 90 to 100%. Cesarean section rate is more in southern zone than the northern area, and it is minimum in the Rajasthan and Bihar. Currently, as per WHO, 1 in 5 delivery is from the cesarean section, and when it reaches to 2030, every 1 in 3 delivery will be done by why the incidence of cesarean section is going high? Because more of the women are becoming mother at an later age. It may be due to the education or career. Most of them are conceived with the ART and have associated multiple morbidities like diabetes and hypertension. There is an increased incidence of the cesarean section on demand from 20% to 30% in recent years due to the maternal autonomy and informed choice. Surgery and anesthesia is now considered very safe due to the better technology, and it is believed that cesarean section has a preventive role in future pelvic floor dysfunction like SUI and pelvic organ prolapse. The obstetricians are also going for cesarean section more frequently as a defensive practice to prevent the litigation and to avoid the vaginal birth complication. The diagnosis of the fetal distress is picked up early nowadays due to the better intrapartum surveillance. The overuse of the cesarean section is nowadays perceived as C-section epidemics, and the general perception of the public and the media is that cesarean sections are done unnecessarily more frequently, especially in the private sector, where it has become a money-making racket. Obstetricians are also being accused for filling their bank account, though the obstetricians are performing the defensive cesarean section early, as they don't want to keep and take any risk, especially in the high risk cases, and they want to avoid the complication of the vaginal birth. Uh, every patient has a right to have a high quality, quality based clinical care. The ethical principle of autonomy directed that the obstetrician also has a duty to help the pregnant woman to make an informed decision and choose the mode of delivery unless the cesarean section is medically indicated. At time when patient under pressure and against her will undergoes the cesarean section on medical ground, and if any complication with bad outcome to either the mother or the neonatal happens, it becomes a case prone for the legal action. Unnecessarily increasing the cesarean section rates is of very great concern to the government, and government has put the guidelines and regulation in place to address the C-section rate and promote the evidence-based practice. Nowadays, it is a must in every cesarean section case to fill a form based on the Robson criteria, and monthly report has to go to the Government of India. It is an initiative to reduce the cesarean section rate by auditing various socio-economic and biomedical predictors like facility, place, region, city, and sector, etc. And those who don't adhere to these regulatory guidelines may face regulatory action. Rising healthcare costs due to the overuse of the C-section has resulted a dispute between the patient insurance company and healthcare providers. And to counteract this allegation, the cesarean section has become a money-making racket in Delhi. Most hospitals, especially the private sector, offers the same rate for the vaginal delivery and cesarean section. I'd like to mention the different type of the cesarean section. The one perimortem cesarean section is the cesarean section, which is also known as resuscitative hysterectomy, and where the cesarean section is performed during the maternal cardiac arrest or during the impending maternal cardiac arrest, with the goal to increase the chances of the successful resuscitation to the mother and also potentially improving the fetal survival. But kindly note, the time to perform the peripartum cesarean section should not be more than 4 minutes of the cardiac arrest, and it is always done in the interest for the mother. Cesarean section birth on maternal request, known as CBMR, is frequently performed nowadays. This is recently introduced and included indication of the cesarean section, especially in cases of the infertility treated pregnancy, those who have a bad obstetric history or previous stillbirth. And it is an elective birth by cesarean section on the request of the woman with no identified medical or obstetric contraindication for vaginal birth. Patient has a right to have a high quality patient-centered clinical care, and it is also commonly observed that educated professional young healthy woman wants to avoid the pain of the vaginal delivery and labor due to the low threshold for the pain and of this young generation, and they also don't want to tolerate the prolonged hours of the labor. They want everything in time rather than the emergency. but it is the duty of we obstetrician to do a detailed counseling regarding the risk benefit both on the short and long term for woman and her baby, and then the patient can make the informed choice as per policy and protocol. They should be also counseled that the cesarean section has a more risk as compared to the vaginal birth. There is also a lack of proper guidelines, which increases the litigation cases. And when I was going through the literature, the RCOG has written that, has agreed that you can agree to do the cesarean section on the maternal request, or you can refer this to the second obstetrician for further discussion and decision, while the ACOG consider it as quite ethical. But it should be noted by everyone that when you are doing the cesarean section birth on maternal request, it should never be done before 39 weeks of gestation. And the RCOG has, in this consent advice number 14, has beautifully given the form which has to be filled with the informed choice of the patient. Most of the litigation which occurs are due to the time delay in giving the consent, in which the patient becomes responsible. But once consent is given by the patient, one should not delay in doing the cesarean section, and the usual time should not be more than 30 minutes from decision to the delivery in cases of the fetal distress, while in non-distress condition, the time can extend up to 75 minutes. A case of the K. Murgesan versus Dr. Sharla Devi, the doctor has waited for the anesthetist husband for 4 hours and also didn't call any other local anesthetist till then. The IUD had happened and intraoperative bleeding started, and the patient has to be shifted, where the patient died on the way and the doctor was held liable. Another very frequent reason of allegation and litigation is to whether the pediatrician was present at the time of birth to resuscitate the baby. So to avoid the litigation, it is always preferred and must to have the pediatrician at the time of birth, whether it is a vaginal or the cesarean birth. Most of the hospitals, especially in the private hospital, a pediatrician or the neonatologist is always available. But legally, when the in private setup of nursing homes or the small setup, where the pediatrician availability is not so easily available, legally any doctor or nurse trained in resuscitation can resuscitate the baby. But the only issue remains, the person has to be trained and he has to prove in the court of law the extent and authenticity of training. Professional bodies like Indian Academy of Pediatrics and National Neonatology Forum regularly are conducting the comprehensive neonatal resuscitation program for doctors and nurses called Neonatal Advanced Support Program, NALS. And it is advisable and recommendation that one should get all the staff, especially the nurses, to be trained in NALS. But in cases of emergency cesarean with fetal indication, it is advisable to have the neonatologist to get away from the litigation. And so again, I say, insist that the pediatrician should preferably be present in all cases of the delivery. Now, what are the prerequisites for the cesarean section, and to modify them as into 8 P's, that is the person, place, protocol, preoperative precautions, proper indication, proper informed consent and documentation, the pediatrician, and possibility of the bleeding anticipation. The next one, the first P is who can perform the LSCS. Ideally, the LSCS is expected to be performed by a gynecologist, but a MBBS doctor or a surgeon with MS degree, when he does, he has to produce in the court the proof about his training on the LSCS approved by the NMC. Further, there is a need also to tell them that the gynecologist was not available for the particular surgery and the situation was life-saving and there was no time to wait for the gynecologist. The next P is what are the places where the LSCS can be done. It can be performed, it should be performed at any registered establishment with OT and indoor facility and with the infrastructure equipped with, where the infrastructure is well equipped with essential equipments like oxygen cylinder, boils apparatus and defibrillator. Also, the protocol for checking the expiry date of drugs, oxygen cylinder filling date, and annual maintenance contracts, and their record has to be kept. Standards should be followed while deciding the list of drugs, disposables, and equipments to be available in the OT. It's not that everyone. Hello. It is not.
Jain, Dr. Jain.
I am not able to listen.
Hello, can you listen me?
Sound is very low.
दोबारा join करिए.
Ma'am, can you listen me?
Yes, ma'am. Yes, ma'am, we can listen.
Yes, ma'am. Yes, yes.
It's very clear.
But there are, it is not possible for everyone to have the conduct the delivery in the private sector or in the government sector where all the facilities are. Can you hear me now?
It is very clear.
Sir, आप disturb कर रहे हो, please बंद कर लो अपनी आवाज.
So the persons who are doing the LSCS in nursing home without the ICU facility, they should tie up with the nearby hospital or with the ICU facility, and they should make sure that the facility for transfer to is also there in case if it is required. What are the essential pre-operative precautions which are very important? Detailed proper history of previous surgeries and medical problems should be always documented, and it should be taken and always it has to be documented. The documented pre-anesthetic note which should be complete with the instruction like medication to be administered and the pre-operative starvation instruction. The one should also in the detailed history must inquire the history of any problem which can affect the anesthesia, like the history of asthma or the drug allergy. And the minimum pre-operative blood tests required are CBC, PT, APTT, blood grouping and cross-matching, and urine test. It is always preferred to keep the availability of the 1 unit of the blood cross-matched during the birth. It's again very important to avoid the litigation. The proper indication, the documentation of the proper indication for LSCS is equally important, as the common allegation related to the cesarean section are that the doctor did unnecessary cesarean section, or they do the allegation that it was done too late and hence the baby suffered. Their documentations should corroborate with the indication, and notes of the nursing staff should tally with that. As we know that the documentation is the only proof of our counseling and communication, and they are the only defense to avoid the litigation. Like if we have a documentation in case of the fetal distress, the proof of the fetal heart recording should be there as an indication of cesarean section for fetal distress, and the scanned copy of the tracing should be kept in the record, as in time with the time the tracing, the ink of the tracing gets fed away. The Obtaining the informed consent for cesarean section is crucial, and it is a legal and ethical requirement also. The consent should be of the patient and patient only. The others are signing as witness unless the patient is of insane or minor. Consent of the husband or the mother-in-law is not valid in conscious patient of sound mind. The informed consent should compromise of all the four components, like it should be the legally with all the detailing about the procedure, its risk, benefit and alternatives, and the whatever the information we give about the risk, it should be in the balanced information, not to frighten her. And if one fails to do so, it can lead into the medical issues. The very important is when to take the consent for the LSCS, and this is the most common dilemma, whether it should be done taken during the fetal distress, or during active labor, or during late antenatal period when you are doing the antenatal counseling, or during the admission for delivery. Now, it is very important that during the antenatal counseling, the detailed counseling should be done in the late third trimester, before the labor, initiation of the labor, about the risk benefit of the vaginal birth versus the cesarean section, the complication associated, and the risk of any patient, even in the low risk group, ending up into the cesarean section during the intrapartum monitoring. And most of the cases we are doing the consent in the during the fetal distress. In cases of the active labor, it is advisable to take the consent in between the contraction. And ideally it should be during the late antenatal period, and again during the antenatal period it should be always documented. You have counseled the risk and the chances of the cesarean section at any time. Also, during admission for the delivery, the consent has to be taken. Now, most of us, we are doing and taking the consent during the either active labor or the during the fetal distress, except in cases of the elective cesarean, when the consent is taken during the admission. And it is not necessary that the treating obstetrician has to take the consent. Even a resident doctor who is quite competent can also take the consent. One should remember the dictum about the consent, that it doesn't imply the consent for other associated procedure like appendectomy or myomectomy or hysterectomy, unless it was life-saving step. Here I like to mention that even when the patient is under spinal or epidural anesthesia, though the patient is conscious, taking the consent on the table for any associated procedure, myomectomy or appendectomy, is not valid at all, and it should never be done. But if you are anticipating before doing the cesarean section, with proper mention in the consent for associated procedure can be done at the time of the cesarean section, like tubectomy or the appendectomy. And also I like to stress, once we are doing the cesarean section during along with the tubectomy, and suppose if there is any complication later on develops, then and if our documents are complete and accurate, then it will not come into the it will not come under the sterilization complication by the government. Usually it is that we don't combine the appendectomy. This is a very common scenario, that if the patient refuses to give the consent, or they are asking to wait for some relative to arrive. So one has to do and document the informed refusal signed by the patient, and also if the patient refuses to sign also, then get an undertaking from about the incident signed by any neutral bystander. But sometimes it also happens that relative refuses to give the consent. At the same time, they don't want to take the woman in labor to other health facilities. So this should be also documented, and witness signature to be taken, which can be not the relative of the patient, but any nursing staff or the any relative of the nearby patient. And one can also inform the police about it. In Mr. Sakil versus Mrs. Sakil, with Dr. P. Arani, the doctor documented the refusal of the consent to the LACS as patient insisted on waiting for her father-in-law, and hence negligence could not be proved in spite of the hypoxic damage to the newborn. Now, this is the most important, vital and crucial role play by the antenatal counseling session, which should be done in all the cases of the pregnancy. One fully devoted and focused counseling session during the antenatal class near term on the pros and cons of the vaginal versus operative delivery, the chances and indication of the intrapartum cesarean section, meconium stent later, liquor and fetal distress with poor fetal outcome in spite of in-time cesarean section, even in the low risk pregnancy, is always helpful on long term to avoid the litigation. The difficulty or delay in diagnosis of the several thunderbolts like PPH, amniotic fluid embolism, pulmonary embolism, DIC in labor and during delivery is equally important to be informed and documented during the antenatal counseling. And so equally it is important to document, because this is the only evidence in the court of law for your counseling. There are two types of the troubleshooter. One who refuse medically recommended cesarean delivery, and the other one who demand unwarranted cesarean section. If everything goes well, nothing will happen. But if there is an untoward or or any complication occurs, either of these two troublemakers, then they will raise the various issues of concerns, including the infrastructure, the facility is not available, the blood facility is not there, the health, the expenses about the procedure, the any anesthetist issue, and the maternal and neonatal health outcome. So one has to be very vigilant and should have a legal eye for picking up these type of the troublemakers, and one has to, especially in these cases, one should document each and every conversation, and they should be counseled beforehand. The most common maternal complication which occurs in the cesarean section are the infection, hemorrhage, and injury to the nearby organs. And if a patient experiences these complications during or after surgery, he and the family thinks it is due to the negligence or improper medical care, and can result into the legal claim against the health care provided and even to the facilities. The neonatal outcome. Most of the elective cesarean section, if performed before 39 weeks of gestation without any convincing medical indication, can lead to the neonatal complication, and then it becomes a case for the legal litigations. So the dictum for LACS remains that it should not be done before 39 weeks as an elective procedure. And the gynecologist can face the legal consequences if any cesarean section done before 39 without any indication results into the harm to the baby. The common allegations in cesarean section litigations are usually anesthesia or anesthetist related before or after the cesarean section procedure, and the amount of the of 25%, and failure to arrange the blood, especially in the placenta previa accreta syndrome, accounts about 40 to 50%. The another common allegation is failure to do the removal of the uterus to save the life of the patient in cases of the PPH well in time. The unfortunate occurrence of the DIC and pulmonary embolism or pulmonary edema and acute kidney injury are another reasons and allegations in cases of the cesarean section. Also, when one fails to recognize and manage the complication, whenever the maternal death due to any cause or during the transfer of the patient to the higher facility is another cause for allegation. Retaining the MOP is not so frequent, but it do happen. Any bad neonatal outcome due to delay in doing the cesarean section or later the development of cerebral palsy, even up to the age of 20 years, or injury to the baby like herb palsy or can lead into the litigation. The unavailability of the pediatrician, and the another important part is the vaginal delivery after cesarean section. As more and more cases, the government is promoting to go for the vaginal delivery after cesarean section, and when in emergency the cesarean section with all the risk of rupture or any hemorrhage is done, it becomes prone for the allegation. And last but not the least, and very important, is the improper consent taken, inadequate or no consent taken at all, the poor communication and documentation, which is the only evidence for your good defense. The bleeding is the most common problem leading to the litigation in cesarean section. One has to be vigilant about the possibility of bleeding in all cases of the cesarean section, and it is prudent to have the blood for cross-matching in all cases of cesarean section. It can happen, and this is very common and encountered very frequently, that blood bank is situated at far away distance, and at least the effort should be made to ring up the blood bank and ask for the availability of the blood in case of the emergency. The case of Dr. D.K. Naik versus Dr. Kalyani, where the patient was unbooked and RH negative with PIH, and when the emergency cesarean section was done, and there was involvement of the bilateral uterine artery, and she died on way to the shift. And the main allegation was that no blood was arranged, it was not as anticipated complication, and there was lack of intensive care. The court held of treating obstetrician liable, and also there was discrepancy between the anesthetist and the gynae notes, and a compensation of 2.35 lakh compensation was awarded. So it's equally important there should be no discrepancy between the anesthetist and the obstetrician notes. The another, as I said it, the vaginal birth after cesarean section is the another situation which is very prone to the litigation. Antenatal counseling and the documentation plays a vital role. The risk of the scar rupture, repeat cesarean section, hemorrhage, fetal distress, all should be documented and counseled during the antenatal counseling session. And our documents should be able to prove that the labor was meticulously monitored and OT was kept ready for emergency section, and it should not be less than 30 minutes to take out the baby, and there should be the judicious use of syntocinon by the infusion pump only in case if it is required for the vaginal birth. A compensation of 2.35 lakhs was awarded in D. Naik, where the patient has undergone the cesarean section while trying for the vaginal birth, as I mentioned it earlier also. So one should remember not to panic. The other common reasons for litigations are PPH, DIC, embolism and hysterectomy following uncontrolled PPH, birth asphyxia and birth injuries like Erb's palsy, post-operative sepsis. And remember, there is no need to get worried by complication. They are known to occur during the surgery, but a honestly and timely explanation, empathy shown for the unexpected outcome can reduce litigation. So to prevent the litigation, there should be the NMC recognized or approved qualification of the operating doctor, and one should always have the evidence-based practice, improve the doctor-patient communication and counseling. Antenatal counseling again plays a important role, especially for both vaginal and operative birth. Cesarean section should be performed only if medically necessary, and it should be an ethical, judicious, and balanced decision. The informed decision by the patient should be given a priority and should be always welcomed. The informed consent should be of only patient, and the consent form should be separate for anesthesia, cesarean section, and blood transfusion always. Neonatal counseling and documentation in high-risk cases before cesarean section should be always done, especially in the preterm babies. Also, the equally important is the presence of neonatologist in each case of delivery. Educating the patients about their rights and risks and benefits of different delivery options can empower them to make some informed decision about their childbirth experiences. Proper documentation with time and date, refusal consent, and no discrepancy in note should be there. Availability of the blood in every case, and one should anticipate complication, counsel, and explain to the patient once it happens, and one should know how to manage these complications. There should be a call for help. Do not hesitate to call your seniors. Always take the help, and also call. There should be a rush team in case of the emergency, and it is always a multi-specialty teamwork. The most important is the proper record keeping. The discharge paper should be in detail with proper follow-up instruction. I like to mention here that in case of the cesarean section, the detailed note should be always there, so that in future, if anyone is not coming back to that doctor, the other treating doctor should know what has gone and why the cesarean section with all the intraoperative finding he should be aware. Last but not least, the professional indemnity. Everyone should have at least of 1 crore in case, not less than 1 crore in all cases of the gynecologist. The document should also prove the degree of care was reasonable and was not less than expected from an average doctor of doing such surgeries. And equally important is to nurture a no blame game. Oh, sorry, I think this has been a new terminology, that is the defensive cesarean section. I'm sorry for being it at the late. I don't know how it was missed out. The defensive cesarean section is defined as a cesarean delivery recommended by the doctor in the absence of any clear medical indication that such a delivery method is needed to avoid possible litigation or a possible accusation of malpractice. And it is an example of the defensive medicine and is defined as the deviation from the medical protocols or guidelines to reduce the number of complaints or criticism from the patient, and it is very frequently practiced in the current area. Thank you so much for the nice and patient hearing.
Thank you very much, Dr. Raj. That was a very exhaustive cover, and I think you covered everything absolutely down to the most minutest detail. I think we are all taking to understand this, that this is the one of the most important aspects, because cesarean section is such a common delivery mode that is being practiced today. So I would welcome now comments. I would start with Dr. Sharda ma'am. Your comments, please. And your expert advice.
Let me just present a few cases.
Yes,